Assalamualaikum and good afternoon. First, I would like to thank the organizers for inviting me. I have nothing to disclose except for the fact that I am not a cardiac anesthetist. I am a regional anesthesia, one of the regional anesthesia trainers for RA subspecialty in Ministry of Health Malaysia. Today, I'll be giving a talk on regional anesthesia, blocks of the chest wall. My focus today would be blocks of the chest wall for cardiac and thoracic surgeries. The outline of my talk will be introduction, brief anatomy and block choices, some evidence for thoracic surgeries and also for cardiac surgeries. And at the end, I will conclude my session for today. So, as an introduction, blocks of the chest wall originated from work for breast surgeries. Various blocks that have been described, from PEX blocks to the Brilmer block, serratus plane block, and also the serratus intercostal and pecto-intercostal facial plane blocks. And it has expanded use with further understanding of the block mechanics. For breast surgeries, there have been a description of the use of PEX, serratus plane, Brilmer, serratus intercostal, pecto-intercostal, and rectus spinae plane blocks. And there have been accumulated evidence for breast surgery, especially for PEX blocks. And from various meta-analysis and trial sequential analysis, they have concluded that the PEX significantly improves quality of analgesia and reduces opioid consumption during the first 24 hours, and efficacy which is similar with paravertebral blocks, with evidence of moderate to high quality, and it is not likely to change with further clinical trials. For chest wall blocks, we know that acute surgical cardiac and thoracic pain are highly associated with chronic pain. And there's a current shift in surgical emphasis towards minimally invasive surgery, and also from the anesthesia side, shifts from high-dose opioid anesthesia to fast-track regimens that expedite early extubation. And it is therefore imperative to provide high-quality perioperative analgesia for cardiac thoracic patients with opioid-sparing or even opioid-free techniques. So, before we decide on what options that we can have for specific procedures, we have to go through basic anatomical considerations. For brief anatomy of the thoracic wall, chest wall innervation comes from the anterior rami of thoracic abdominal intercostal nerves, and they run anteriorly from beneath their respective ribs within the plane between innermost and internal intercostal muscles, and they give off an anterior branch and a lateral branch. The lateral branches emerge through the planes of serratus anterior around the mid-axillary line and divide into their anterior and posterior cutaneous branches respectively. And the anterior branches emerge through the planes of internal intercostal muscle around the lateral edge of sternum and divide into medial and lateral cutaneous branches respectively. Okay, this is a diagram of what I've mentioned just now. And the ultrasound guided blocks of the chest wall can be divided into the central techniques, which consists of thoracic epidural and also thoracic paravertebral, and the peripheral or interfacial approaches. And these can further be divided into blocks of the lateral branches and also blocks of the anterior branches. Blocks of the lateral branches are the Brilmer block, PEX2, serratus plane block, serratus intercostal facial plane block, and the wrist block. whereas those that blocks the anterior branches are the pecto-intercostal facial plane blocks, transversus thoracic plane, and the parasternal pecs. And there are also peripheral approaches that blocks both branches, which is the erector spinae plane block. For the central techniques, this is where we deposit our local anesthetic. This is for thoracic epidural. And this is for thoracic paravertebral blocks. And the erector spinae plane block, this is where we can deposit our local anesthetic just beneath the erector spinae muscles. And it blocks the hemithorax and blocks both the anterior and the posterior rami. Whereas the peripheral or interfacial approaches, those blocks that covers the lateral branch are the Brilma block, serratus plane, serratus intercostal facial block, and also the PEX2, and lastly wrist block. So these are the area where we deposit our local anesthetics. And these blocks can provide analgesia or anesthesia to between anteriorly lateral to the clavicle and posteriorly lateral to the mid scapula. The peripheral approaches that blocks the anterior branch are the pecto intercostal facial block, transversus thoracic block, and the parasternal pecs. And this just covers the anterior branch, just lateral to the sternum and up to the medial end of the clavicle. So what about the evidence for thoracic surgery? What do we know currently? There have been a variable level of evidence with the use of PECs, serratus plane, pecto-intercostal, transversus thoracic, and erector spinae plane blocks. And in recent years, there has been multiple quality level of evidence that, especially in serratus plane block for thoracotomy and thoracoscopic surgeries. And there have been meta-analysis over the last 2-3 years. And there's also a systemic review by Jack in 2020. And as for the evidence, the meta-analysis by Liu in 2020 looked at 8 RCTs covering 542 patients. There were also evidence of moderate to high quality. What we have currently basically comparing serratus plane to non-block care or conventional techniques. And there's also one meta-analysis by Chong that compares serratus plane versus paravertebral block. The surgical scope was heterogeneous, and there was also a study among thoracoscopic surgeries by Zhang. And there's also procedure and comparator-based qualitative review by Jack in 2020. So as of now, what we know is that serratus plane reduces pain scores up to 24 hours, but mainly in thoracoscopic surgery, and there was no difference found for thoracotomy at 6 hours and 24 hours. Serratus plane reduced opioid requirements at 24 hours, and it was quoted by these 2 studies, up to 12 milligrams. There's also a reduced time to first analgesia, up to 193 minutes, and there's reduced incidence of PONV. However, there has been no meta-analysis versus other RA comparators. As for erector spinae plane, there have been 2 studies, one by Huang and Kai, comparing ESP versus non-block care and also ESP versus paravertebral blocks, also covering heterogeneous surgery. The quality of evidence has been low to moderate or moderate to high in these two studies. And what they found was that ESP for thoracic surgeries reduces pain scores up to 24 hours and reduces opioid requirements at 24 hours up to 17.2 milligrams, reduces PONV, and ESP were found to be similar to paravertebral blocks in terms of pain scores and opioid requirements at 24 hours. So I would expect that the evidence for serratus plane would follow the experience following PEX blocks, which from systematic reviews to meta-analysis and studies via trial sequential analysis, and later on proceeded to recommendations and guidelines. And all this experience following PEX occurred over a period of 8 to 9 years. So probably serratus plane block, the evidence for thoracic surgery may probably follow a similar trajectory, and ESP probably much later in their evolution. So what about evidence in cardiac surgery? There have been increased description of use with understanding of the anatomical concept, and it was well illustrated by this narrative review by Kuala. This group actually describe detailed use of specific blocks for specific type of surgeries and what options to cover for specific incisions. However, there's been limited evidence so far. There have been described of the various blocks being used for cardiac surgeries, the PEX blocks, pectointercostal facial blocks, transversus thoracis block, and erector spinal plane blocks. But they have found use for serratus plane block for minimally invasive cardiac surgeries. But most of the studies were against placebo or conventional analgesics, and few were against RA comparators. There has not been any meta-analysis as yet. As for sternotomy, erector spinal plane block may be the block technique of choice. It was first described in bypass surgery by Tsui, whereby they inserted a bilateral ESP catheter and gave a bolus of local anesthetics every 90 minutes in the ICU. And within 3 hours of admission, the patient was extubated. The catheter was discontinued at day 2, and the patient was discharged at day 3. So there was a qualitative best evidence review done by Misra and Awal, and they've identified only 7 studies, and only 2 of them were randomized control trials. And they found that for sternotomy, the use of ESP, patients had comparable VAS scores to thoracic epidural, and ESP provided superior analgesia of longer duration with improved recovery. And the conclusions from the other studies also, they found that there was a reduced time to extubation and reduced ICU stay. So another option for sternotomy are the blocks of the anterior branches of the intercostals. Which one is the choice? Either parasternal or pectointercostal facial block or the transversus thoracis. Well, the evidence so far have been limited to case reports, series, and small RCTs with the use of wide indications. The pain for sternotomy has actually not been well understood. It may involve supplies from the lateral branches. Hence, there are some studies that incorporated the use of PEX blocks into blocks of these anterior branches. and they found that those incorporated with PEX block had better scores. But of the blocks, transverse thoracic muscle plane block has the more robust evidence so far. And there have been recent RCTs on pectoral-intercostal facial blocks and also transverse thoracic block, even in the pediatric population. All provided similar outcome parameters, and these benefits can be divided into analgesic-based and also function-based. They are found to have reduced pain scores and reduced morphine requirements. And they also provided improved pulmonary function parameters, improved oxygenation, reduced time to extubation, and reduced length of ICU stay. So when comparing ESP and the blocks of the anterior branches of the intercostals, which one is more superior? As far as I'm aware, there has not been any RCTs that compare both the blocks. I guess I think whichever is good in your hands probably will provide a better outcome. Before I conclude, I would like to share with the audience an excerpt from a paper from Balen. This actually listed down the details of the options and also the current regimes for the various available blocks that is currently in practice for cardiac surgery. And almost all of them actually use volumes of between 20 to 40 mils of local anesthetics. So in conclusion, early evidence for interfacial plain block use in cardiothoracic procedures remain encouraging, and understanding of anatomical coverage is paramount in terms of selection of appropriate block approach. There have been proven immediate perioperative benefits for serratus plain block and erector spinal plane, and in both were found to be non-inferior to thoracic paravertebral for thoracic procedures. Serratus plane or PEX may have limited role in cardiac surgery, but they may have a role for minimally invasive thoracotomies. ESP may have a major analgesic role to play as an integral multimodal analgesia component in enhanced recovery after cardiac surgery. We await further accumulation of high-level evidence to corroborate these early interesting findings. With that, I thank you.